Good afternoon and welcome to the second Institute of Health Studies satellite seminar in this series. We're broadcasting from the University of Plymouth, and in the studio today we are very pleased to welcome Liz Fradd, who is the Director of Nursing for the Commission for Health Improvement. Before joining CHI, Liz was the Assistant Chief Nurse in the Department of Health. Also in the studio today we have Professor Mary Watkins, Director of the IHS and Professor of Mental Health Nursing. And you've got me. I'm Ray Jones and I'm Director of Research for IHS. What we will do in this next hour is first Liz will give a presentation for about half an hour to 40 minutes, and then we will have some discussion. CHI was formally established in April 2000 with the explicit aim to bring about demonstrable improvement in the quality of NHS patient care throughout England and Wales. Liz's presentation is entitled The State of the NHS, the Emerging Themes from CHI's Clinical Governance Reviews. At the end of her presentation, she will join us again here for discussion. That will be your chance to contact the studio with your comments and questions. Now, there are three ways in which you can contact the studio, and details of these will appear on your screen in a minute. I will tell you again after Liz's presentation, but if you have a pen and paper handy, you should note them now. You can phone in on 01752 233 646. Alternatively, you can send a text message to 077 866 43257. Or lastly, you can email us on tvstudios@plymouth.ac.uk. As well as viewers down here in the southwest of England, we hope to have viewers from around Britain and possibly elsewhere. So it would be good for us to have some idea of how many centres and people are tuned in today. Maybe one person at your centre could contact the studio using one of those three methods during Liz's presentation in the next half hour, to say where you are and how many are viewing at your centre. So now we go over to Liz Fradd.
Thank you very much indeed, and a warm good afternoon to everybody. I want to start my presentation this afternoon by providing a little bit of context about the Commission for Health Improvement, about why it was created, some of the roles that we have, and then move fairly swiftly to some of the emerging themes that have come from our work, predominantly from our clinical governance reviews. So what were the three key things that we were looking at when we were first set up? First of all, to try and change the focus of healthcare management from the cost of healthcare to the quality of healthcare. Also, to try and restore the public's confidence in the way in which NHS care was being delivered, notably because of so many major service failures that had hit the press. And thirdly, because, as many of you who work in the NHS will recognise, there is huge variability between organisations caring for patients across the NHS. Our key original roles were, first of all, to undertake clinical governance reviews in every NHS organisation across England and Wales. Very early in our work, we realised that some organisations needed to be brought forward in our reviews because of serious concerns. Now, whilst our second responsibility is to investigate serious failure, we felt at times there was the need to not just replicate investigations that had already taken place. And so we introduced the notion of fast-track clinical governance reviews, where we felt a perfectly adequate local investigation had occurred, but perhaps some of the broader issues in relation to systems and processes had not been looked at. So our first responsibility is to do the clinical governance reviews, our second to investigate when there is significant service failure. Thirdly, to provide advice and information and some leadership around clinical governance. This is one of the areas where we have had perhaps less activity, but where will be more guidance being produced shortly. And then finally, our fourth responsibility when we were first set up was to study the implementation of the National Service Frameworks and NICE guidance. Since then, however, of course the world has changed, and we had the publication of the Kennedy report. And immediately after that, a number of things changed for CHI and the focus within which we work. Recently, the NHS Reform and Healthcare Professions Act has been passed, and in it we now have a responsibility to undertake inspection with special measures, to also develop an office for healthcare performance, and thirdly, to provide an annual report to Parliament. The annual report to Parliament is intended to be an indicator of the independence of CHI. But of course the world has moved again since then, and some of you will recall that after the last budget it was announced that there would be a completely new organisation called the Commission for Inspection and Audit. And that came into the document, the NHS Plan, Next Steps on Investment, Next Steps on Reform. And there, within this means that there will be a huge change to the existing Commission for Healthcare Improvement. First of all, the new organisation will be having obviously a different title. It will take on board all of CHI's current responsibilities, but also a number of others. Firstly, the National Care Standards Commission's responsibilities for the whole of the private sector. That's all of the private hospitals and the private clinics. We will also be taking on board the Audit Commission's Value for Money studies in health, and the Mental Health Act Commission, and it's likely that there will be an element of responsibility also for complaints, possibly at the second stage, and to oversee the process. So you can see that this is going to be a quite different organisation, much larger, and with different chairman and chief executive. So where are we now with our experience of clinical governance reviews? The evidence that I'm going to be sharing with you this afternoon comes from 166 published reports, 64 of which have been published since April of this year. And this is our current programme, and you can see from that programme that the number of organisations that we're currently reviewing is over 90, and across a wide range of different organisations. Those include all of these different types of organisations for which there's a completely different methodology for each. Importantly, we have brought people in from the NHS to help us to develop our methods so that we're sure that they will reflect the reality of where we're going to be reviewing. And you will note that at the bottom of that list, we are beginning to look at how we will review whole health communities rather than looking at single organisations, which doesn't really reflect the way in which patients cross barriers. CHI's model for clinical governance illustrates our belief that the way to be effective in the delivery of clinical governance is to have a culture which is dependent on continuing improvement through continuous learning and development. And you will see from this model that there are three main areas within our model, each of which has components. And these are what are commonly known as the technical components of clinical governance, of which the top 7 are well recognised, particularly by organisations, for example, like the Clinical Governance Support Team, who use the same technical components. Early on in our work, we found that actually those 7 technical components did not cover the full range of the issues that we were looking at that have an influence and an impact on patient care. And so we have added 2 additional ones. That's the patient experience and strategic capacity. Notably, within strategic capacity, the capacity to improve. Currently, we assess each component of clinical governance, that's the top 7, and score them, and the bottom 2 we describe. There are 5 stages of a review, and it's important that this is understood because many people working in the NHS only really experience the 1-week visit, which comes around about the middle of the process. But actually it's a much more complex process than that. The first part is the collection of data, the analysis of data, and the tracking of that through our complex computer process. Then, of course, there is the site visit, which many of you will have experienced. And then we move into the reporting phase and significantly for me are the last two phases. The first is the action planning, because this means that the report doesn't just sit on a shelf. Something has to happen as a consequence of the findings. And lastly, the ongoing performance management, the monitoring of the action plan. I just wanted to take you through a little bit about our approach to our methodology, because this is important, because it reflects our 6 principles. They are that we would be patient-focused, that we would concentrate on the patient's experience rather than the experience of NHS professionals, that we will be open, accessible, that we will be evidence-based, that we will look to being developmental and to continuously improve, that we will be independent, rigorous and fair, and importantly that we don't expect others to do what we don't expect of ourselves. So in line with those principles, we're committed to involving the NHS and patients in the development both of our process and in the doing. So we have lay reviewers as part of our team and NHS staff who are peer reviewers. We also spend a lot of time evaluating our methods and improving the approaches we take with the development of new tools. We've been trying to learn from policy and research that's already in the literature, both from this country and abroad, to ensure that both the way in which we undertake our work and report it is reflective of best practice. Importantly for us, there is complete transparency of the approach that we take. We have our assessment framework and our methods on our website, and many organisations use them for their own self-assessment. Importantly, our experience is that we are the only inspectorate that not only analyses both qualitative and quantitative data, but that we code it, we triangulate it, we analyse it, and we also track it so that at any point when a question is raised, we're able to look for the original source of where our evidence came from through a very sophisticated software program. Also, we're committed to ensuring that reviewers, peer reviewers, are involved in the process. We believe that they give us much greater credibility by using people out in the NHS who are knowledgeable about the NHS and are still experiencing working within it. And there has been much talk about whether or not we should take this approach, or whether indeed we should have professional inspectors. It's interesting that Mori recently did a survey of teachers, 8,000 teachers, who overwhelmingly favoured the use of serving teachers to undertake the Ofsted inspections. Ofsted currently has professional inspectors. We believe that there's a huge opportunity for personnel and for employer development. And in particular, from a recent survey of our own staff, of our own reviewers, 59% of our reviewers said that they had acquired new skills as a consequence of working with CHI, and 80% said that they had actually built on their existing skills. So things like interview skills, analysing skills, the management of information, team working, those sorts of things. Many of them also said that it had improved their opportunity to get promotion. We have also achieved clinician input without exhausting the service, and this has been important. We've had to try and find ways of bringing senior clinicians in to work with us, both on our methodology, in evaluation, but also in the reviews themselves. Our assessment centres, both for our own staff but also for our reviewers, is robust. And the important thing is, as I said, that we have lay reviewers who ask those questions which perhaps many of us would be too embarrassed to ask. And of course that is all supported by a multidisciplinary team within CHI. Many of the people working in CHI come from the NHS, not all, and of course the people that don't bring a freshness too. Within CHI we have our own internal quality mechanisms which ensure both the quality control of our product through the tracking of the process, utilising quality managers, assistant directors for clinical governance and people like myself, but also the quality assurance of the whole programme through ensuring, as I've said, that we utilise methods which are research-based and that we evaluate as we go through. We don't use standards for our work. We don't create standards. We believe this is a costly and bureaucratic way of managing the methodology, and there's also great difficulty in keeping them up to date. However, what we do is expect that organisations will use national standards that are produced by the real experts in those areas, for example, Royal College standards. There is wide variation within trusts, but we have noted that there is considerable progress that's being made. And whilst the way in which we make judgments about each component part of clinical governance is not supposed to be comparative, we have, and I will show that to you, done an analysis of how the scores pan out across the NHS. Each of the component parts of clinical governance are scored using this framework for scoring, a 1 to 4 point scale. The important part about this is that to score a 1, there would be seen to be very little strategic planning, poor operational use of a policy or a strategy, and perhaps not connectedness across the organisation. To score a 2 is much more complex, and because it's hugely variable what is within an organisation. So this might reflect the fact that there is very good strategy, planning for, say, risk management. It might well be operationalised in parts of the organisation, but it isn't connected across the whole organisation, so that limits it to a 2. Or there might be a very good strategy for risk management, but actually this has not been operationalised at all. Or there's no strategy, but in spite of that, clinical teams have managed to operationalise risk management at their own level. So the score of 2 is quite a complex one. 3 is excellence. That is where there's a strategy, where it's well operationalised, people all the way down through the organisation know about it, and where there's connectivity across the organisation. And then finally we score a 4 for those organisations which have achieved excellence and beyond. In other words, they know where they're going next. They've got something else that they're striving for. There's always the opportunity to improve. And this slide demonstrates how the NHS broadly is scoring 2s across most of the clinical governance technical components. There are organisations that have scored a 2. We now have 2 organisations that have managed to score a 2. One of them actually managed to score 2 4s. And then some organisations are scoring 3s as well. But broadly, most of the NHS is scoring 2s. And I don't want to stress that too much because it was never designed to be comparative across organisations, but this should offer some reassurance to organisations that they're not too far distant from their neighbouring trusts. Before I go into the themes, I want to make this point very, very clearly. In all of our work, we find caring, committed staff who are sensitive to the needs of patients. They're committed to providing quality care and to quality improvement. However, often in our reports, that statement or similar has a caveat beside it, that they are doing that against all the odds, in cramped circumstances, with reduced resources, or whatever the situation is. But it's important that we recognise that the vast majority of people working in the NHS are working hard and are committed to the care they're providing. What I'm going to share with you now are the top level recurrent themes that come out of our published clinical governance review reports. And the first 4 themes occur in over 90% of all of our published reports. They've been there right from the beginning, and they remain there. They've not changed. They jostle in terms of which one comes out at the top, but they've always been there. These are the themes which come out of our acute reviews, However, these first 4 also appear in the first 8 pilot reports of our PCTs. Now, anybody looking at this would say, well, of course the NHS is reactive rather than proactive. And we understand that because so much comes down from the centre, which you're expected to do. But actually, this bullet isn't about that. This is about, and I'll use risk management again as the example to take through. This is about organisations that are not, for example, undertaking a risk assessment throughout their organisation, rather than being proactive and thinking about how they might avoid something from happening. So in other words, they're not thinking ahead of an incident, they're responding when an incident has occurred. We find too often that there is a need for an organisation-wide strategy, either for clinical governance per se or for elements of clinical governance. Quite often we find that clinical teams have developed their own mechanisms of working quite adequately, but that it's not the same mechanism, not the same strategy, not the same framework across the whole organisation. Where policies and strategies do exist, they are often not implemented. An example I would give you is of an organisation that has a perfectly good whistleblowing policy, for example, which the Trust Board has signed off and has disseminated. But when we do our reviews, we don't just go in and tick the box. What we're interested in is to see how well that whistleblowing policy is known right across the whole organisation. So we interview staff at all levels, and that's why we select 3 or possibly 4 clinical teams so that we can drill down through the organisation to get a feel for how well these sorts of things are understood and accepted. So if we use the whistleblowing policy as an example, it might be that the staff nurse, the healthcare assistant, either knows about it or doesn't. If they know about it, it might be that they don't understand how to use it. It might be, even if they know how to use it, that they don't trust the person that they would want to whistleblow to. And if they have used it, it might be that it hasn't actually been fed all the way back to them what the outcome is of the thing that they have reported. The need to share between organisations and within organisations is a striking issue in all of our reports. What we find is really good things that go on in every organisation we go into. Our reports report notable practice as well as the things that people need to do better. It's a pity that perhaps the media doesn't always pick that up, but if you look at our reports carefully, there is always notable practice in them. The sad thing for us is that Ward X, that has managed to sort out a problem which is common across the whole trust, has resolved it in an innovative and creative way, has not shared it, and so when we go into Ward B, they know nothing about it and they're struggling with exactly the same problem. So there is something about the sharing of good practice, even within organisations, and also sharing the learning that comes out of complaints, investigations, those sorts of things too. These next 2 themes feature in over 80% of all of our published clinical governance review reports. And they do in part reflect what I've just said. The first of these is about organisations not communicating from the top all the way down through to people working at ground floor level. I heard an American guru in quality at a recent international conference in quality speaking about just this issue, and he described it as being a bit like a chief executive who's got a very large desk in front of him full of buttons, and when he pressed the buttons, nothing happened, nobody responded, and he couldn't understand why. And then when he went round to the back of his desk, he saw that the wires to the buttons weren't all connected in. And this is exactly what this is about. This is about there not being flows of information, communication down through an organisation and across it. And the second one is, sadly, that still we find that specialised areas of care and disciplines can themselves be barriers to affecting change. So maternity services don't talk to care of the elderly, mental health doesn't talk to children's services, doctors still not talking to nurses, nurses to allied health professions. This is about multi-professional, interdisciplinary working. The component parts of clinical governance that cause us the greatest concern are these four. And what I'm going to do now is just to take you through them in a little bit of detail, just indicating the issues that are of concern to us, but also to show you the other side, to demonstrate to you where we have found good practice. So first, on risk management. Well, this is just exactly what I've been describing, the issue about being reactive and not proactive. There being poor environments in some places which is not conducive to staff avoiding risk, cramped circumstances, limited equipment, lack of ventilation, lack of light, those sorts of things. No analysis of patient complaints or staff surveys. So again, staff not having feedback from when they have been involved in surveys or indeed patients. Poor attendance at mandatory training. Indeed, there's quite a widespread misunderstanding about what mandatory training might be. People interpret it in different ways, and often no database kept for people to monitor who has been on training and who needs to go again. Clinical staff shortages are very apparent in some of the organisations that we go into. We don't have a tool to make an assessment as to what organisations need. That's not for us to do. What we look at is the effect that staff shortages have on patient care and on the ability of staff to be able to deliver good quality care. And strikingly, for me as a nurse, infection control measures being poorly implemented. I think this is very often because infection control teams are very often small, they're isolated, they tend to be managed in isolation from other clinical governance issues. They have great difficulty in connecting to the clinical governance agenda and to the committee. We find organisations that still don't report on infection control at trust board level. But there is good stuff going on in the NHS around this issue. And this is one at Dewsbury, the telephone reporting system. Often people say to us, we don't have time for all of this, we can't manage this in our busy lives. But this is a really good example of an organisation that's found a mechanism for people to be able to do it. They've got a telephone system for reporting incidents. And not only that, but a system then to analyse those incidents and the steps taken to ensure that they're prevented from happening again. At Brighton, they run a training programme called Your Mother Wouldn't Like It. And I'm quite sure my mother wouldn't like quite a lot of what I do and quite a lot of what goes on in the NHS. But I think this title actually sums it up exactly, that what we're trying to do is the best for patients. And a very good test of that is whether or not our own families would approve of the way in which care is being delivered. Staffing and staff management. We find that too often there is no systematic approach to the way in which workforce planning is done. By that I mean it's not integrated. Yes, of course workforce planning goes on, but it's usually done in isolation. The doctors their workforce plans are done separately to nursing, nursing is done separately to the allied health professions. And at a time when there are so many changes in the roles of all of the professional groups working across the NHS, there is a need now to integrate the way that those workforce plans are done to reflect new roles and new ways of working. There are still in many places a lack of creative approaches to recruitment and more particularly to retention. And I'll link that to this next point, which is about the failure to provide career opportunities, and to the last bullet on this slide, which is about the lack of staff appraisal systems. Those are all connected together. If staff aren't being regularly appraised, if they're not being encouraged, supported, enabled, guided, then we're not going to get them staying in the NHS. There are too many places where there has been failure to implement the Working Time Directive for junior doctors, and there is still very poor management of temporary, locum, bank and agency staff working in our hospitals. Poor induction, poor support, poor supervision, and it links to the next bullet around the failure to check registration. But there are good things going on. In North Bristol, there's an excellent mechanism for nurses to demonstrate what their workload needs are by patient, with the use of a pen and this barcoding above the patient's bedside. For me, this is excellent because it is responsive to the need there and then, rather than in the longer term for workforce planning. Patient involvement is another area where we have serious concern. And the involvement of patients is not what perhaps we have historically thought of as patient involvement. I'm not meaning involvement in the giving of their own medicines or the dressing of their own wounds. It's not that sort of thing, although obviously we encourage that too. This is about being involved in decisions that the Trust Board is making, about decisions about the environment in which patients are being cared for. It's about them being involved in research and audit. And it's obstructed by the lack of information for them and the lack of opportunity. There are also significant barriers for many people to make complaints about the NHS. Either the complaints leaflets aren't in the right language, they aren't at the right level for patients to understand, or they're just simply not available, they're hidden under a great big rack of other leaflets, or the Trust has not actually changed its complaints leaflet after a merger, and the wrong names are on the leaflets for people to make the complaint to. And again, the good practice where this is going on is not being shared. And this is one example, Greater Manchester NHS Direct, where patients have been involved in the planning and development of the NHS Direct services, and in particular mental health patients, which is not easy to do. And again, in Leicestershire, the partnership trust there, where there's a ward where they have a whiteboard which they use for discussions during the doctor's ward round, and at the completion of the doctor's ward round they print it off and they're able to give that discussion document to the patient. In Stockport there's the patient user group in neurology who are influencing the way in which literature is produced by that directorate for the benefit of patients with the same sorts of problems. And finally, the use of information. Use of information has been a serious concern of CHI right from the beginning, and is one reason why we are now being asked to develop the Office of Performance Information. Everybody, I think, who works in the NHS will be well familiar with the poor collection of information and data, the poor analysis, and then its poor use afterwards. We find many organisations where trust boards are not familiar with their own data and information, where clinicians are not receiving it back for their own use to determine different ways of delivering health care, but also clinicians are not being able to readily access trust policies or NICE guidance or other national protocols. And finally, in this section, we have found a need for people to observe the Caldecott guidelines more succinctly. We find too many occasions when patient records and patient x-rays, for example, are left lying around in public places, or the ability for us to access into medical records departments unchallenged. But again, there is notable practice, and at Shrewsbury the pharmacists have developed their own software which enables printouts to be developed so that they can be given to both people working in the trust and moved on to the GPs on discharge. And in Durham they have the IT system whereby the wards and clinics can get both previous and present x-rays which actually aid diagnosis more speedily. And in Bromley they've got their intranet where they've got all of their policies and procedures which actually helps to support staff to manage their care better. Now those are the themes that come out of our acute reviews, and remember that the first 4 that I mentioned also are the ones that are beginning to come out of PCTs. I'm now just going to rapidly just go through some of the themes that come out of our mental health reviews. Many of these are replicated from what I've previously talked about, and I won't go into too much detail. Perhaps most importantly to say is that clinical governance, we believe, is less well developed in mental health. The patient experience for us, of course, is an extremely important one wherever patients are cared for. But in this particular environment, we found that there was a lack of planned therapeutic activity for patients who were inpatients, inconsistent approaches to the management of violence and aggression, and a very variable approach to the implementation of the care programme approach. Surprisingly, user involvement still has a long way to go in some mental health organisations, and I for one had always thought that in mental health that probably they were doing this rather better than many others. There is some good development, particularly in the recruitment and training of staff, but often it's still very service specific. Risk management is also embryonic and again reflects much of what I've already said about risk management. They do have good incident reporting in many organisations, but it's very often reactive, and there are significant weaknesses in the way in which the risks around the management of violence and the way in which drugs are administered to patients. There is poor quality of inpatient environment, in some places a staggering lack of understanding about patients with mental health problems needing the same standard of accommodation as acute care patients. And in audit and effectiveness, again, still at an embryonic stage, very similar to other places, very uniprofessional, somewhat limited in terms of the support that staff have, feedback and dissemination. And in staffing and staff management, explicitly staff shortages around psychotherapists and psychiatrists, and for inpatient nurses. But there are some good examples of how staff are working collaboratively with social care, although there is some very variable supervision of staff. And in strategic capacity, there is still a disconnection, as we've already explored in the acute side, a disconnection between corporate level and those people that are working within clinical teams. Particularly, this is the case where there are disparate spread localities, and the level of support for people working out in isolation is a worry. Poor development of information systems is very, very similar. Now, this is quite a complex slide. It's actually it's demonstrating some comparisons with our investigations. And the bit that I think is the most important for people to grasp here is that out of the 7 investigations we've published, there are some marked similarities to what I've just been talking about. But in particular, across all of those 7 published reports, there is a notable isolation of small services, a lack of multi-professional working, a lack of accountability lines. So what has been CHI's impact on the NHS? I'm just going to share with you 1 or 2 things that we know have happened as a consequence of CHI publicly reporting. First of all, we know of one organisation that got additional funding for nurses in a coronary care unit where there had been only 1 nurse on duty at night to support 4 monitored coronary care patients and 12 other patients monitored in a ward next door. The appointment of a paediatric surgeon for the first time in one organisation. The reduction of a large number of additional patients in 4-bedded bays, which has obviously ensured that safety is not undermined. The significant improvement in the environment of one A&E department, both the physical environment and also the culture within the organisation for those people to provide care. The funding of additional staff to go in a mental health unit out into some of the disparate localities, and the funding for mental health nurses in a large teaching hospital A&E department where they were experiencing significant difficulties. And finally, I want to share with you the experience of one medical reviewer, a consultant obstetrician, who as a consequence of one of the reviews that he's undertaken with us, went back to his organisation and implemented 3 new things. He changed something about prescribing, he developed a new protocol, and he has also developed a new resource centre for patients. And I think that that really sums up everything that I've been trying to say in my presentation, which is about CHI and the NHS working together to ensure continuous improvement, quality development of services for patients, and continuous learning. Thank you.
Okay, thank you very much indeed, Liz. That's a very interesting presentation. Liz is going to come and join us just now. Just a reminder to people out there viewing that you can phone in on 01752 233 646. You can text if you want to on 077 866 257, or lastly you can email the studio on tvstudio@plymouth.ac.uk. At this point I'll hand over to Mary Watkins, who will start the discussion.
Well, thank you very much, Sue. I'd quite like to ask you, Liz, I'd like to ask you a question. You talked about a reviewer going back and changing the practice. To what extent do you think people in the service are changing practice in preparation for the review?
I think that's a good question. We know that because chief executives tell us that the mere fact that they know a review is coming acts as the catalyst for quite a lot to happen. We tell organisations 3 months in advance of us beginning work with them, and then there's a 3-month period where we collect data and information, so they actually have 6 months before we actually step foot into the organisation. So I think the letter popping through the letterbox can sometimes be what they call the wake-up call. But now that we've published so many reports, and some of them of course have been quite high profile, I think that people now are beginning to see that the quality agenda that's attached to clinical governance is of an equal importance to things like the performance indicators, which many organisations have actually spent most of their time working on.
Right. Thank you very much.
We've got one email that's come in from Veronica Maynard in Truro, which asks about what universities can do in this in terms of the research. Yes. How does research fit into the work of CHAI?
Right.
And, because it's mainly about applying what we already know rather than finding new information. Do you want to say something about that?
Yes, and I'm delighted that question's been asked, because I think it has two parts for me. One is in terms of pure research. There are a number of universities that are researching the impact of CHAI's work. Birmingham, Manchester, King's Fund, all sorts of places are now doing substantial pieces of research, and I think that could develop even more. But I also think, for me, there is something about universities hearing the sorts of messages I've just given and ensuring that the skills are appropriate for people to be able to deliver care in a different way in the future. So there is something about the way in which we prepare our professionals to take account of some of those things. And I think whilst many of them are well known, there's no surprises. I don't think anybody's going to have gasped at anything I have said this afternoon. But I think what it does do is it crystallises for us where some of the things are that we're still not doing well. So I think there is something about thinking about how we prepare people, and there is something about the pure research side which the universities can take on.
Yes. And how do you work at the moment with taking forward those examples of good practice? I mean, and whose responsibilities? I mean, you gave the example of the Dewsbury telephone reporting system on infection control, which is something I think which would probably strike a chord locally here quite a lot, and with one of our PhD students as well in Plymouth. How do we take that good example and get others to follow it?
Yes, and this of course is the bit which, as you would expect, the ministers are particularly anxious that we should ensure happens, and there's a variety of mechanisms. I mean, this is one: conferencing, publishing, writing, speaking, working with some of the change agents like the Modernisation Agency, working with some of the champions in some of the areas of specialty. So we've been doing some work with some of the Royal Colleges. For example, yesterday I was at the Royal College of Paediatrics and Child Health talking to them about the things that come out explicitly for children, and equally we're doing other pieces of work with, for example, George Alberti we want to meet to talk about the things that come out around emergency services. So there is something about making sure the messages get to the people who can be champions for those particular areas of care. But I think we need to find other new mechanisms too. So one of the things we're going to be doing over the next year is pulling just 3 of those 4 themes that we said were causing us greatest concern: use of information, patient involvement and risk management, and looking at the evidence that we've collected to try and produce some guidance to help people to do it better. But we're not going to do that from CHAI alone. We're going to involve the NHS, there'll be some consensus work that will go on, and we will draw people in at all sorts of levels, and I would hope that universities will be part of that, so there's some true ownership of how we move it forward, because I think it's not good enough just to talk about it and see it in print. It's actually something about, there's something active that has to happen to make it change.
I wonder if I could ask you another question. I was very interested in the infection control issue. I mean, some of the people watching will know that I was a student when you were a sister, and I remember the stringency with which your ward was run in terms of infection control. But do you believe that at the moment we haven't got that right in curriculum at undergraduate level, or do you think something happens after people qualify?
Well, Mary, far be it from me to say that you haven't got it right in the curriculum.
I was meaning nationally rather than just in Plymouth.
I think it goes back to what I was just saying. I think there is something about those messages that people need to reflect on who are part of curriculum development and the delivery of programmes, to see why those things which are long-standing, they're not new, have still got a place as a cause for why things aren't good for patients. There is undoubtedly, though, a distance between what people are taught, in my mind, and how they behave in practice. Now, one could say that's partly about, and I mentioned it, and that's about sometimes the risk within the environment is such which mitigates against people performing well, and in this instance, infection control. So if you don't have, for example, a wash basin nearby, then you have to think of something else that will ensure that people actually make their hands are clean. So we have, for example, I know of one organisation that has scrub beside each bed, because the sinks are far distant. And I think there's something about logically thinking through, why is this the case in our hospital and why is it different somewhere else? There are some infection control teams that are incredibly active, and even without asking the questions, it's obvious they're around the wards. You can see it happening just from our site observations, and in others one is really searching to find evidence that they have been involved in patient care and in supporting the staff. So I think there is inevitably I think some distance between what people are taught and how they practice.
Yes, it's quite interesting, because years ago we were taught a very routinized way of behaving. And I can remember when I first went to work in the community that I'd only ever done a dressing with a pack that had 5 cotton wool balls, and opening the community dressing pack and discovering it only had 3, and actually for the first time having to problem solve rather than follow a routine. And some of the criticism of curriculum has been that we've taught principles recently without teaching the practicality. And I wonder whether there ought to be, in the way that there's mandatory training for lifting and handling, for example, that I think within our curriculum we're very clear about, whether there should be mandatory training for infection control, and you'll not be surprised, I believe, for management of potentially violent situations, regularly reviewed on an ongoing basis. Do you think? I mean,
I think that would help, but I also think there's something about scenarios, introducing. It isn't a perfect world that we live in.
No.
And I think we have to be real about that. But I think we sometimes present the image that this is the way it is to be done, and then it's very hard when you get onto the street and it's different. So I think presenting students with a set of different challenges and scenarios is another way of doing it. And I know that some universities are doing this well.
Yeah.
And,
so you think the opportunities for problem-based learning that is interprofessional are key to some of this for the future?
Absolutely. Yeah.
Thank you.
What's the case with the private sector? I mean, how does CHI work with the private sector? And now we're seeing patients even going abroad. I mean, what happens there? I mean,
well, at the moment, CHI isn't going into the private sector. Except where the contracts flow across. So, for example, in one of our mental health trusts, where there were mental health patients that were the trust's mental health patients but cared for in the private sector, what we looked at was the quality element of the contract and how that was ensured by the trust being maintained. However, in the new world, in new CHI, the new organisation will have responsibility for the private sector. That's the private hospitals and the private clinics.
Okay, right. Now we've just got another email there from Plymouth, which is asking about the lay involvement and the professional involvement in the way that the two different groups review the evidence that they're approached with? I mean, it basically asks, do the lay members of your teams have different interpretations of the data from the professional members, and is there ever any conflict between the two?
Well, the first thing to say is that they are recruited through the same system, so they go through exactly the same assessment in order to be a reviewer as a professional person. They are trained in exactly the same way. It is multi-professional training with the lay people going through the same training programme. What we do is put a module in front of our core training for those people that know nothing at all about the NHS, so that they get a feel for what it's like. Inevitably, that's the whole point about having people from a range of different backgrounds, inevitably there will be different perspectives that people bring to the arena. However, the training is very clear that they are leaving their baggage of being a nurse, their baggage of having been a doctor, and in the instance of a layperson on one side, and they use the assessment framework in the same way. They're encouraged to do that. So it's a very rigorous use of the framework and of the scoring system. And the way in which evidence is tracked and triangulated ensures that we don't get somebody who has a maverick view. So we don't report single observations or single pieces of evidence. It has to be triangulated, and triangulation, I shouldn't be talking about this in a university setting, but it is not about 3 people telling us. It is 3 totally different sources. So it might be patients, it might appear in documentary evidence of, say, a trust's board's minutes. It might be that it's come from an observation. It has to be 3 completely different sources. So that helps to stamp out that sort of slightly maverick possibility. And we're very conscious of that and very aware of it. And that's why every review is headed up by a review manager who makes sure that the team think together. And that they share those views. They're encouraged to share them, but that then the interpretation is a joint team interpretation, not one person. It's never that.
Do you have that?
I have got another question.
I've got another email, but we'll take yours first, yes?
Right, you are. You talked about 7 investigations. Could you just explain to us the difference between a normal review and an investigation, and how an investigation gets called for?
Okay, the way it gets called for is either the Secretary of State in England or the Minister for Health in Wales can ask us to do it.
Right.
And our first 2 investigations were brought to us in that way. So that was the North Lakeland investigation in mental health and the Carmarthenshire investigation in Wales. Or we can select to do it ourselves. And we do that in 2 ways, either from the information that we ourselves collect, and Barnet and Chase Farm is a good example of that. It's not yet published, but we did a clinical governance review, which is published. We were significantly concerned about an issue, and because of our concern, we then decided to do an investigation into the issue of concern, and I'll come back to the differences. Or we might have people referring stuff to us. And that can be a member of the public, it could be a professional, or it could be an organisation. Right. And then we have criteria against which we make a judgment about whether or not an investigation is warranted. And as I was saying in my presentation, we have a large number of referrals. But we try to tease out those that are new and fresh and haven't been investigated, or have been investigated to a point where actually they need to be rescoped. And perhaps Gosport was a very good example of that. That was the Portsmouth Community Hospital, where there had been police investigations, where there had been internal investigations, but the breadth of it was such that we felt that it warranted an investigation. Now, I've forgotten the second part of your question now.
Well, it was really how they came about, and yes. I think you've answered that. But I didn't understand whether it meant any member of the public could refer to CHI and where that sat in the structure. Really.
Anybody can.
Right.
But what we do say is that they must have gone through the full NHS complaints procedure, because what we won't do is interrupt into a local matter. It's not appropriate for us to do that, and we couldn't possibly cope with all of that either.
Right. Thank you.
I just got an email here from Taunton asking about how your relationships with the press and how they interpret your work because of the possible blame culture that it might encourage. You want to comment on that?
Yes, we have really quite a large communications department headed up by, I think, a brilliant director of communications who's got a lot of experience in this field. We try to court our relationships with the press, in particular the professional press. So the HSJ, for example, we meet with regularly. The other press, the local press and the newspapers and television, radio, we tend to encourage to be involved in our process. So, for example, right at the beginning of our clinical governance reviews, part of the process is to actually engage the public as stakeholders to give us evidence about the organisation we're going into. And so we do work with local press, radio, television and newspapers particularly, to tell them what it is that we're doing, why we're doing it and what we would like the public to do with us. And so we build up that relationship right at the beginning of the review and then at the end. The problem is, of course, the stuff that they really want to report is the stuff that can make headlines. And I fail to understand why good issues don't make headlines, but they don't. And in spite of the fact that all of our press releases have good and less good issues, they're always balanced, as our reports are, and in spite of the fact that every time I'm interviewed for the television or the radio or the newspapers, I talk about the good and the less good, the good bits always get clipped out, unless I'm talking live, and that's my only opportunity to get the good stuff in.
Well, I think you've had quite a good opportunity to get the full picture of the work of the Commission today. We're nearing the end of our time, so I'd like to thank Liz very much for coming and giving this presentation. I'd like to thank Mary for joining in the discussion, and I'd like to thank you at home for your participation in the seminar. The next IHS Satellite Seminar is on Thursday, November the 14th from 2 to 3 p.m, when Heather Newton will be discussing the role of nurse consultants. As always, the seminar is open to all, so put the date in your diary, tell your colleagues and friends, and we look forward to your participation then. Goodbye.
Thank you.